Welcome back to the deep dive. Today, we're really immersing ourselves in a condition that's, well, profoundly complex, highly heterogeneous.
Yes, and often dangerously misunderstood, psoriatic arthritis or PSA.
Right. It's a critical subject.
It really is because, for too long, PSA has been sort of casually dismissed. People might say, oh, it's just arthritis with a skin rash.
But it's so much more than that.
Absolutely. As we synthesize the literature, the true picture emerges. This is a chronic inflammatory powerhouse. It's formally categorized as a seronegative spondyloarthropathy.
Okay, that term itself, seronegative spondyloarthropathy, tells us a lot, doesn't it?
It does. Two key things right away. First, it involves the spondylo part and peripheral joints. Second, seronegative means it's typically negative for those classic autoantibodies, like rheumatoid factor.
Which you see in rheumatoid arthritis, for instance.
Exactly. And that distinction, being seronegative, that's really where the diagnostic challenge often begins.
Yeah, because you don't have that easy blood test marker always. We know PSA happens in people with skin or nail psoriasis.
What's the figure?
Up to 20%.
That's right, up to 20% of the entire psoriasis population. So you're talking about hundreds of thousands of individuals facing a potentially quite debilitating disease.
And the severity can be all over the map, right? Mild annoyance for some.
And for others, rapidly destructive joint damage. It's incredibly variable.
So our mission today...
Our mission is really to give you a shortcut, a deep understanding of this multi-domain disease. We're going to unpack the incredible variety of its clinical manifestations.
Okay.
We'll highlight those subtle but vital diagnostic clues that help separate it from its mimics, conditions that look similar.
Like RA.
Like RA, yes.
Yeah.
We'll also explore the tangled roots of its pathogenesis, the genetics, the environment, the biomechanics involved.
And finally, treatment. Because it sounds like that needs to be very specific.
Incredibly targeted and domain-specific. We'll get into why that is.
Okay, but if someone listening only remembers one thing about PSA's sort of deceptive nature, what should it be?
I'd say remember this. There's often a profound disparity between how bad the joints are and how bad the skin looks.
So they don't always match up.
Not at all. You might have a patient with really minimal, maybe hidden psoriasis, perhaps just a patch on the scalp or, in the gluteal folds, somewhere not obvious.
Right.
But at the same time, they could be experiencing rapidly destructive arthritis in their hands or feet. That lack of obvious skin plaques, it absolutely does not mean the joints are safe.
That's a crucial point. Don't judge the arthritis by the skin cover.
Precisely.
Okay, let's unpack this clinical signature then. When we say PSA is highly heterogeneous, what does that really mean in practice?
It means the disease just doesn't follow a neat, predictable script. It can be mild and localized in one person, but in the next person, it can be aggressive and multisystemic, affecting lots of different areas.
So how did clinicians try to make sense of this variability?
Well, historically, back in the 1970s, Moll and Wright described 5 distinct clinical patterns.
Okay.
Now, we recognize today that most patients actually experience a blend of these patterns, and it can change over time. But these 5 are still sort of the bedrock for classifying how PSA can look.
Let's walk through them. I think that really illustrates the spectrum.
Good idea. So the most common initial presentation is often asymmetric oligoarthritis.
Oligo, meaning few joints.
Exactly. Affecting fewer than 5 joints, often large or small ones, and typically more on one side of the body than the other. Asymmetric.
Got it. What's next?
Then we have the pattern that causes the most diagnostic confusion. Symmetric polyarthritis.
Poly meaning many joints, symmetric meaning both sides.
Correct. 5 or more joints affecting both sides of the body. And this is the one that can look clinically almost identical to rheumatoid arthritis, RA. Makes it tricky.
Okay, so those first 2, maybe less specific. What about the patterns that really shout PSA?
Right. That's where we get to pattern number 3. Distal arthritis. This is really unique. It involves the distal interphalangeal joints, the DIPs.
Those are the joints closest to the very tips of the fingers and toes.
That's them. You almost never see RAs starting there, but for PSA, it's a classic hotspot.
Interesting. And number 4?
Number 4 is, thankfully, the least common, but it's the most aggressive. Arthritis mutilans.
Mutilans sounds pretty severe.
It is. It's a dramatic, rapid, destructive process. You get severe bone reabsorption. The finger bones, the phalanges, essentially collapse into themselves.
Wow.
It leads to this highly specific appearance called the telescoping of the digits. The finger can literally be shortened and pushed back, like a collapsing telescope.
That's a really stark visual marker of just how destructive this disease can be.
It absolutely is.
And the fifth pattern,
The fifth is spondyloarthritis, or SPA. This focuses on the axial skeleton.
meaning the spine.
The spine and the sacroiliac joints, the SI joints, where the spine connects to the pelvis.
Okay, so those are the 5 historical patterns, but you said most people have a mix.
Yes, that's the critical thing to understand now. While these 5 types exist, the majority of patients, maybe up to 65%, actually have multi-domain involvement.
So they might have, say, peripheral joint issues and back problems.
Exactly. They might start with that oligoarthritis, few joints, but then years later develop axial disease, maybe some enthesitis. The disease isn't static, it evolves.
Let's focus then on 2 features that, kind of regardless of those patterns, should immediately put PSA high on the suspicion list. You mentioned dactylitis and enthesitis.
Absolutely. These are really unique signatures of the disease, often differentiating it from RA.
Tell us about dactylitis, the sausage digit.
Yes, and sausage digit is a fantastic descriptor, actually.
Yeah.
It's not just a single joint swelling up.
Yeah.
No, it's this diffuse, uniform swelling of an entire finger or toe. It looks like a uniformly painful, tight, often reddish sausage.
And what's actually swelling there? Is it just the joint?
That's the key. It's not just the joint. It's caused by inflammation of the joints plus the surrounding soft tissues, most notably the tendon sheaths.
The protective sleeves around the tendons.
Exactly, like the flexor tendons in the hands or feet. This combination, synovitis, joint lining, capsulitis, joint capsule, and tenosynovitis, tendon sheath, all swelling together gives you that sausage look.
And that's specific.
Highly specific to PSA and other related spondyloarthropathies. It occurs in nearly half of PSA patients. And importantly, having dactylitis is seen as a poor prognostic factor.
Meaning it suggests a tougher course.
Yes, it's highly associated with an increased risk of progressive radiographic joint damage down the line.
Okay, so dactylitis is one hallmark. What's the other? Enthesitis.
Right. Enthesitis, first, what's an enthesis? It's simply the site where a tendon or a ligament or even the joint capsule inserts directly into the bone.
Okay.
Now, RA typically targets the synovial lining inside the joint. PSA, however, has this tendency to attack these insertion points, these entheses.
So where the soft tissue anchors to the bone?
Precisely. There's this concept of the synovial-enthesial complex, suggesting the enthesis and the tissues right next to it act like a single inflammatory unit in PSA.
Where would someone typically feel enthesitis?
Common spots are the Achilles tendon insertion in the back of the heel, the plantar fascia on the sole of the foot causing heel pain, the patellar tendon insertion just below the kneecap, and also various spots around the pelvis.
So if you have a patient with, say, inflammatory heel pain, maybe where their Achilles tendon meets the bone, especially if they also have a sausage digit.
That's a massive red flag for PSA, even if their other peripheral joints seem okay at that moment.
Wow.
Yeah, enthesitis is considered a major domain of the disease. It's noted in over a third of patients and really contributes significantly to chronic pain and functional limitation.
Okay, let's shift to the skin and nails. We said psoriasis often comes first, sometimes years before the arthritis.
That's the typical pattern, yes. A median of maybe 7 to 8 years between skin onset and joint onset.
But what about the cases where it's the other way around, or the skin stuff is really hard to spot?
That's the diagnostic trap. We know somewhere between 7 and 15% of patients develop the arthritis before any noticeable skin lesion appears.
Yeah.
That's the group that's most challenging to diagnose early on.
And even if the skin is present,
It can be hidden, sequestered away in the scalp, behind the ears, maybe in the gluteal folds or inside the umbilicus, the belly button. A clinician really has to actively search these areas.
you can't just rely on seeing big plaques on the elbows and knees.
Definitely not. And then there are the nails. They offer another major clue.
How so?
Well, nail disease is remarkably common in PSA. We see it in 80 to 90% of patients who have the arthritis.
Wow, 80 to 90%. That's much higher than in people who only have psoriasis, right?
Much higher. In uncomplicated psoriasis, it's maybe around 46%. So nail involvement is a strong pointer towards arthritis developing or being present.
What kind of nail changes should you look for?
The classic features are pitting looks like tiny pinpricks on the nail surface. On onycholysis, that's where the nail plate actually separates from the nail bed underneath.
Okay.
And nail bed hyperkeratosis, where the tissue under the nail gets thick and crumbly.
Is there a link between the nail problems and specific joints?
There often is. Crucially, the severity of the nail involvement frequently correlates directly with inflammation in the adjacent DIP joint, that joint right at the fingertip.
So bad nail, bad nearby joint.
It's often a physical manifestation of the inflammation spreading from the tip of the digit inwards, a very useful clinical sign.
Now let's broaden out again. PSA isn't just joints, skin, nails. It's a systemic thing, right? What other extra articular manifestations pop up?
It's absolutely a whole-body inflammatory disease. Debilitating fatigue is a big one, reported in nearly a quarter of patients.
And morning stiffness.
Yes, significant morning stiffness, often lasting more than 30 minutes. Very common.
What about the eyes? Are they involved?
They are a major target. Ocular inflammation is common. It can range from conjunctivitis, pink eye, which happens in about 20%,
Okay.
to the more serious condition, uveitis, inflammation inside the eye, seen in about 7%.
Is the uveitis in PSA different from other related conditions?
It can be.
Yeah.
If we look specifically at uveitis in PSA, it often presents a bit differently than in, say, ankylosing spondylitis.
Mm-hmm.
It tends to be more frequently bilateral, both eyes, and more insidious.
Insidious meaning slow onset.
Yes, slow to start and more chronic, maybe less acutely painful compared to the often sudden, painful one-sided attacks you might see in classic AS.
Okay. And the gut. We mentioned spondyloarthropathy is often linked to gut issues.
Precisely. PSA patients have an increased risk of inflammatory bowel disease, IBD, that's Crohn's disease, or ulcerative colitis. This connection really supports this emerging understanding of the gut-joint axis, this idea that inflammation in the gut can influence inflammation in the joints. We'll touch on that again when we talk pathogenesis.
Anything else less common but still notable?
Well, though less typical, we do sometimes see cases of chronic lymphedema or pitting edema, sort of persistent swelling, usually in the legs or arms. Sometimes that can even precede the joint symptoms.
So a really wide range of potential signs and symptoms beyond the joints themselves.
Definitely. It requires looking at the whole patient picture.
Okay, that clinical picture is definitely complex, a moving target almost. So now we have to ask why. Why is the body attacking the joints, the tendons, the spine, the skin, sometimes all at once? Let's shift to the roots, the etiology and pathogenesis. Genetics first.
Genetics are huge in PSA. It's profoundly genetic. We know it's highly heritable because it clusters strongly in families.
Right.
But here's the catch. There isn't one single PSA gene we can point to. It's what we call a polygenic disorder.
Meaning multiple genes involved.
Exactly. Multiple genes, each contributing a sort of low to modest amount of risk. It's the combination that matters.
Let's talk about the strongest genetic links we know of, especially in that MHC region, the major histocompatibility complex, those HLA genes.
Right. The HLA genes are crucial because they present antigens to the immune system, basically telling it what to react to. The most famous one, especially for the axial component, the spine involvement, is HLA-B27.
B27 is linked to ankylosing spondylitis too, isn't it?
It is. And it's also strongly associated with an increased risk of axial involvement in PSA. Somewhere between 40 to 60% of PSA patients who have spine disease are B27 positive.
How does it contribute?
The thinking is it's involved in how the immune system responds, perhaps inappropriately, to things like bacteria, and how that response then targets the entheses, those insertion points we talked about.
Okay, but the gene that's most strongly linked to the skin disease, psoriasis itself, is different, right?
It is. That's HLA-C0602. This is the classic psoriasis gene, often linked to an earlier onset of the skin lesions.
Does it play the same role in PSA?
Interestingly, its association is actually weaker in PSA patients compared to those with just uncomplicated psoriasis. And when CC0602 is present in someone with PSA, it often suggests maybe a later onset of the arthritis and perhaps a milder course, particularly for the peripheral joints.
So that difference itself is a clue, isn't it? That the drivers for skin versus joint disease aren't identical?
Exactly. It tells us the mechanism driving the skin part isn't entirely the same as the one driving the joint part, even though they're clearly related.
Beyond the HLA genes, are there other key genes involved in the inflammatory pathways?
Oh, yes. We've identified several other risk alleles outside the MHC. Particularly important are genes involved in those inflammatory signaling pathways we keep mentioning. Think IL-12A, IL-12B, and the receptor for IL-23, IL-23R.
Ah, the interleukin genes.
Right. These are all components of that critical IL-23, IL-17 signaling cascade. So the genetics really set the stage for the specific kind of immune dysfunction we see in PSA.
Let's talk about that immune mechanism then. You mentioned the IL-23, IL-17 axis. Can you break down why that pathway is so central here?
Okay, think of the immune response like an emergency notification system. IL-23 acts like a major signal that really kicks off a massive inflammatory cascade.
Yeah.
It promotes the development and survival of specific immune cells called T helper 17 cells, Th17 cells. And it also activates another group called type 3 innate lymphocytes, or ILC3s.
And what do those cells do?
These cells are basically pre-programmed cytokine factories. Once activated by IL-23, they pump out large amounts of IL-17.
And IL-17 is the problem.
IL-17 is a potent pro-inflammatory cytokine. It drives inflammation directly and is particularly good at recruiting neutrophils, those white blood cells that rush to sites of inflammation, into the tissues.
So it's like an over-escalation. The signal IL-23 leads to the weapon IL-17 being deployed excessively, and we find these Th17 cells and ILC3s right in the affected joints.
Precisely. Studies show they're increased in the synovial fluid, the joint fluid of PSA patients. It's a key pathway. The second really critical pathway is the TNF pathway.
Tumor necrosis factor alpha.
Right. TNF-alpha is another master regulator of inflammation and cell signaling. We know it's critical because TNF inhibitors, drugs that block TNF, are highly effective across the board in PSA. They calm inflammation in both the joints and the skin.
When you actually look at the immune cells inside an inflamed PSA joint, say in the synovial fluid or tissue, how does it look different from, say, rheumatoid arthritis?
There are some key histological differences. In the PSA synovium, the joint lining, we tend to see less thickening, less hyperplasia compared to RA.
Okay.
But what we do see is marked vascularity, lots of blood vessels, and a heavy influx of specific types of cells. Notably, we find a predominance of CD8 plus T cells in the synovial fluid.
Those are the cytotoxic or killer T cell?
Their presence, along with more monocytes and neutrophils, those PMNs, than you typically see in RA, suggests a perhaps more targeted, specific immune attack on the joint tissues, distinguishing it somewhat from the broader inflammatory response often seen in RA.
Okay, so the immune system is clearly keyed up, hypervigilant. What kind of environmental factors might actually pull the trigger and set this off?
Well, infection and the microbiome are definitely major suspects. There's a long proposed link to streptococcal infection, partly because we know strep throat can trigger a specific type of psoriasis called guttate psoriasis.
Right.
More broadly now, there's a huge focus on the concept of dysbiosis.
An imbalance in our microbes.
Exactly, an imbalance in the composition and function of the microbial communities living in our gut and on our skin. This dysbiosis might lead to increased
through that and get through.
Potentially, yes. Inflammatory signals or bacterial products could leak out from the gut and travel via the bloodstream to trigger inflammation elsewhere, like the joints. This is a core idea behind that gut-joint axis we mentioned.
That covers systemic triggers.
Yeah.
But what about local triggers? Physical injury. This idea of deep Koebnerization sounds intriguing.
It really is. It relates to the disease's connection with biomechanical stress. You know, the Koebner phenomenon in skin psoriasis, where a new plaque appears in a site of skin injury, like a scratch. Well, the idea of deep Koebnerization is similar, but for the joints and enthesites. PSA can sometimes seem to develop specifically at sites of physical injury or chronic mechanical stress.
Leading to this concept of mechanoinflammation.
Precisely. If you have that genetic predisposition, then repetitive mechanical stress, think of a runner constantly loading their Achilles tendon enthesis, might actually trigger a local inflammatory response right at that stressed insertion point. The minor tissue damage from the stress could release danger signals that activate the immune system locally, kicking off that whole inflammatory cascade right where the biomechanical load is highest. It could initiate the cycle of enthesitis and subsequent joint damage.
Fascinating. And we also can't ignore a major metabolic trigger, obesity.
Absolutely not. Obesity is now recognized as an independent, significant risk factor for developing both skin psoriasis and psoriatic arthritis. Often the weight gain precedes the actual diagnosis.
And it's not just the extra weight causing stress.
No, it's more than that. Fat tissue, adipose tissue, isn't inert. It actively secretes inflammatory molecules called adipokines. These add to the overall systemic inflammatory burden in the body, influencing not just the risk of getting PSA, but also its severity and how well treatments work.
Okay, one last piece of the pathogenesis puzzle, and it's a really unique one for PSA, this paradox of bone remodeling. You said destruction and creation.
Yes, this is arguably the definitive radiological fingerprint of PSA. It's characterized by the bizarre coexistence of two opposing forces acting on the bone, often right next to each other. bone erosion, breaking bone down, and new bone formation, building bone up.
It sounds counterintuitive, like trying to demolish and build a bridge simultaneously.
It kind of is.
So how does the body manage to destroy bone in PSA? What drives the erosion?
The erosion is driven mainly by increased activity of osteoclasts. These are the cells whose job it is to resorb or break down bone tissue.
Okay.
In the inflamed PSA joint, the synovium, and the underlying subchondral bone, these osteoclasts get hyperstimulated. They're exposed to high concentrations of inflammatory mediators, especially arginine-KL and TNF-alpha.
And that leads to?
That leads to the classic erosive changes we see on X-ray, including that famous pencil and cup deformity.
Explain that.
It's where the destructive process has literally whittled away the end of one bone, making it look like a sharpened pencil point, and the adjacent bone surface has eroded and widened into a cup shape around it. It's a result of severe osteoclast activity.
But then right next to this destruction, you get new bone forming.
Exactly. Almost paradoxically, the body also tries to repair or perhaps stabilize the damaged, inflamed area through ossification, laying down new bone.
What does that look like?
This process leads to things like bony fusion called ankylosis, where joints literally fuse solid. In the spine, it leads to the growth of bony bridges between vertebrae called syndesmophytes.
Driven by different signals, presumably?
Yes, this new bone formation involves different signaling pathways, primarily things like the Wnt pathway and BMPs, bone morphogenetic proteins, which are critical signals for bone growth and repair.
So it's this specific dual pathology, the erosion side by side with the bone building, that really helps distinguish PSA radiologically.
Absolutely. It sets it apart from the primarily erosive picture of RA, or conditions that mainly cause bone formation, like DDish, for example. It's a key feature.
Okay, given this incredibly complex picture, the heterogeneity, the hidden signs, the weird bone stuff, making the diagnosis sounds like it requires a pretty high index of suspicion.
It absolutely does.
When should a clinician really start thinking PSA, especially if the classic skin plaques aren't obvious?
You really have to suspect PSA in any patient who presents with inflammatory arthritis, swollen, painful, stiff joints, but also has some of those specific non-RA features we've discussed.
Such as?
Things like DIP joint involvement, that asymmetry in the pattern of affected joints, definite dactylitis, the sausage digit, or clear signs of enthesitis, like that Achilles pain or plantar fasciitis.
And since the skin disease can come later, or be hidden,
you must ask about a family history of psoriasis. And you must do a thorough skin exam, specifically looking in those hidden areas, the scalp, behind the ears, the navel, the gluteal cleft. Don't just rely on the patient reporting obvious psoriasis.
Let's talk labs. What are the clues there? Or maybe the lack of clues?
Sure. The big headline is that PSA is typically a seronegative disease.
Meaning negative blood tests.
Negative for the key rheumatoid antibodies. Now, rheumatoid factor, RF, can occasionally be positive, maybe in 2–10% of PSA patients, which can cause confusion.
Okay.
But the absolute critical differentiator, the test you really rely on, is the anticyclic citrullonated peptide antibody, anti-CCP.
And that is?
Anti-CCP is highly specific for rheumatoid arthritis. It's almost never present in psoriatic arthritis. So if you have a patient with inflammatory arthritis, maybe symmetric polyarthritis, it looks like RA, but their anti-CCP test is negative. And they do have some of those PSA hallmarks, like nail changes or dactylitis. You should be strongly leaning towards PSA. A negative anti-CCP is a very important clue.
What about the general markers of inflammation, like ESR or CRP? Are they helpful?
This is another challenge, actually. These inflammatory markers are notoriously unreliable in PSA.
Really?
Yeah,
Not
no.
always elevated?
No. The acute phase reactants, erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, are elevated in only about 40% of PSA patients, even when they have active disease.
Only 40%, wow.
Yeah. So having a normal or low ESR or CRP does not rule out active, progressive, potentially destructive joint disease in PSA. You can't rely on them to gauge activity in the same way you might in TSA.
Okay, so labs can be tricky. Let's move to imaging. What specific features on a standard X-ray point towards PSA?
On X-ray, we're looking for several things. We already mentioned the involvement of those DIP joints at the fingertips. We look for the erosions, especially that pencil and cup deformity if it's present.
Right.
And crucially, we look for signs of that new bone formation happening alongside the erosion. Things like periostitis, inflammation of the bone lining, making it look fuzzy or bony spurs, or even early signs of joint fusion, ankylosis.
And in the spine or pelvis?
For the axial component, we're looking for a sacroiliitis, inflammation of the SI joints. In PSA, this is often asymmetric, meaning one side looks worse than the other.
Okay.
And the new bone formation in the spine, those syndesmophytes, the bony bridges, they also have a unique look in PSA. They're often described as bulky or chunky, non-marginal, meaning they don't just neatly follow the edge of the vertebra, and they might skip vertebral levels, not forming a continuous bridge.
How does that compare visually to the spine changes you see in classic ankylosing spondylitis, AS?
It's quite different, usually. In classic AS, the sacroiliitis is typically symmetric, both sides affected equally. And the syndesmophytes are usually thin, delicate, marginal, right at the edge of the vertebral body, and they tend to progress symmetrically up the spine, eventually leading to that classic fused bamboo spine appearance.
So asymmetric SI joints and bulky, non-marginal syndesmophytes really suggest PSA-related spine disease.
Yes, there's strong pointers towards PSA affecting the axis, rather than classic AS.
What about using more advanced imaging, like ultrasound or MRI, especially if X-rays are normal early on?
They are incredibly valuable, particularly for detecting subclinical or early disease. Power Doppler ultrasound is fantastic for this.
What does it show?
It's very sensitive for visualizing active inflammation blood flow within the joint lining, synovitis, and importantly within the tendon sheaths, tenosynovitis, in cases of dactylitis. It's especially good at picking up inflammation at the entheses, those insertion points, where the inflammation might not be clinically obvious just by feeling it.
An MRI.
MRI is vital, especially for looking deeper at the axial skeleton and soft tissues. It can detect subtle bone marrow edema, swelling within the bone, right at the entheses or within the SI joints, long before X-rays show damage.
So it can pick up the inflammation itself.
Exactly. In fact, some MRI findings suggest that enthesitis might actually be the primary deep lesion that starts the process in PSA, even before people develop obvious peripheral joint swelling. It helps catch the disease very early.
Okay, let's quickly run through how to distinguish PSA from its main mimics. We've touched on RA, but let's nail it down. Key differences.
Right. Rheumatoid arthritis, RA. If you see symmetric polyarthritis, you have to differentiate. PSA is distinguished by DIP joint involvement, asymmetry, even if polyarticular, the severity might differ side to side, the presence of dactylitis or enthesitis, big clues, and any radiologic evidence of new bone formation. And, of course, that crucial negative anti-CCP serology.
Okay, next mimic. Ankylosing spondylitis, AS.
As we just discussed, the axial component of PSA can look like AS, but the imaging is key. PSA tends to have asymmetric sacroiliitis and those bulky, non-marginal syndesmophytes. Classic AS is typically symmetric sacroiliitis and thin, marginal syndesmophytes. Also, PSA usually has more significant peripheral joint involvement alongside the axial disease, whereas AS tends to be overwhelmingly axial, maybe with some hip or shoulder involvement.
What if someone comes in with just one acutely hot, swollen joint? Could it be gout?
Absolutely. Gout is always in the differential for an acute monoarthritis. And it's complicated by the fact that psoriasis itself is associated with higher uric acid levels, hyperuricemia. So PSA and gout can definitely coexist in the same patient.
So how do you tell them apart in that acute setting?
You really have to do an arthrocentesis, put a needle in the joint and aspirate the fluid. Then you examine that fluid under a microscope, specifically looking for the characteristic needle-shaped monosodium urate crystals of gout. If crystals are absent and the patient has other PSA features like nail changes, dactylitis, or a family history, then PSA becomes much more likely as the cause of the acute flare.
Got it. Crystal analysis is key. Finally, what about osteoarthritis, OA? It's so common and it can affect the DIP joints too.
Yes, this can be tricky, especially in older patients where OA is prevalent. The main difference is the type of joint change. In OA, the changes, like Heberden's nodes to the DIPs, are typically hard, bony, and nodular, reflecting cartilage loss and bony overgrowth.
Right.
PSA, on the other hand, usually involves more diffuse soft tissue swelling around the joint, warmth, tenderness, clear signs of active inflammation. Plus, if you see those specific PSA nail changes right next to the affected DIP joint, or if the patient also has enthesitis or axial symptoms, that quickly points away from simple OA as the sole diagnosis.
Okay, that makes sense. Now, just to give this diagnostic journey some structure, are there formal classification criteria used?
Yes, primarily for research and clinical trials, but they're useful conceptually. The most widely used are the Caspar criteria classification of psoriatic arthritis.
How do they work?
To meet the Caspar criteria, a patient basically needs to have evidence of inflammatory joint disease, like arthritis, spondylitis, or enthesitis. And then they need to accumulate at least 3 points from a checklist of PSA-related features.
What's on the checklist?
The checklist includes things like Having current psoriasis, that gets you 2 points right away, or having a past history of psoriasis, or a family history of psoriasis, 1 point each for those. Having typical psoriatic nail lesions, 1 point. Having current dactylitis or a history of it, 1 point. Being negative for rheumatoid factor, 1 point. And having radiological evidence of juxta-articular new bone formation on hand or foot x-rays, 1 point.
So you need inflammatory joint disease plus 3 points from that list.
Exactly. It's a pretty specific and accurate tool designed to confidently identify PSA patients within a larger group of people with arthritis, mainly for ensuring consistency in studies.
All right, we've established PSA is incredibly multifaceted. It hits the peripheral joints, the spine, the tendons, the skin, the nails. So it follows that the treatment approach needs to be equally sophisticated, right?
Absolutely.
Yeah.
Treating PSA effectively is complex. It often requires coordination between multiple specialists, definitely a rheumatologist, often a dermatologist, and the primary care physician plays a key role too.
And what's the guiding philosophy now?
The core principle is the domain-based approach.
Domain-based, meaning?
Meaning you tailor the treatment based on which specific aspects or domains of the disease are most active or causing the most problems for that individual patient. Is it mainly peripheral arthritis? Is it axial disease? Is enthesitis the biggest issue? Dactylitis? Or is the skin and nail involvement the primary concern?
Because different treatments work better for different domains.
Exactly. A drug that's great for skin psoriasis might not touch axial spine disease and vice versa. So you have to identify the dominant domains and choose therapies known to be effective for those specific targets.
And the overarching goal is?
The goal is a treat-to-target strategy.
Okay, what target are we aiming for?
The target is usually achieving clinical remission, meaning virtually no signs or symptoms of active disease, or at the very least, achieving a state of low disease activity.
And you adjust treatment until you hit that target?
Yes. The idea is to assess the patient regularly, typically every 3 months or so. If they haven't reached the target of remission or low disease activity, you adjust the treatment, maybe increase the dose, switch drugs, or add another agent until you get there. It's a proactive approach.
And you mentioned early intervention is key.
Paramount. There's solid evidence showing that patients who get diagnosed and start effective treatment, usually seeing a rheumatologist, within just 6 months of their symptoms starting, have significantly better long-term outcomes.
Better how?
Less joint damage seen on x-rays down the line, and better physical function. Delaying effective treatment allows irreversible damage to accumulate. So that first 6 months is a critical window. Every month really counts.
Okay, let's talk specific treatments. Starting with peripheral arthritis, the joints in the arms and legs, what's the initial approach there?
Typically, you start with conventional synthetic disease-modifying antihematic drugs, or CSD-MARDs.
Like methotrexate.
Methotrexate is often the first choice, yes. Sulfasalazine and leflunomide are other common options in this category. Methotrexate is popular because it has shown benefit for both the joint symptoms and the skin psoriasis, although sometimes the skin responds better or faster than the joints do initially.
No, wait, what about hydroxychloroquine? That's a common CSD-MARD used in RA. Is it used in PSA?
Generally, no. Hydroxychloroquine is usually avoided in PSA.
Why is that?
Well, firstly, the evidence for its benefit specifically in PSA joints is pretty inconsistent. But more importantly, there's a known risk that hydroxychloroquine can actually trigger a severe flare of the underlying psoriasis. It can sometimes cause a widespread serious skin reaction called exfoliative dermatitis.
So the potential risk to the skin often outweighs any potential joint benefit.
For many rheumatologists, yes. Given that risk and the availability of other effective CSD-MARDs like methotrexate, hydroxychloroquine isn't typically a go-to drug for PSA.
Okay, so if those CSD-MARDs like methotrexate don't provide enough relief for the peripheral arthritis, what's the next step?
Then you escalate to the advanced therapies. These fall into 2 main groups, the biologics, or BDRs, and the targeted synthetics, or TSD-MARDs.
And what kinds of drugs are in those categories?
This is where we have agents that target specific inflammatory pathways very precisely. We have the highly effective TNF inhibitors. We have IL-17 inhibitors like secukinumab and ixekizumab. We have IL-12/23 inhibitors like ustekinumab and guselkumab. And we have the oral JAK inhibitors like tafasitinib and upadacitinib.
Quite a few options. How do you choose?
The choice often depends on, again, the specific domain involvement. For example, if skin disease is also a major problem, some agents might be preferred over others. But all these classes have shown good efficacy for peripheral arthritis if CSD-MARDs fail.
Okay, now let's pivot to axial disease, the spine and the SI joints. Does that initial CSD-MARD approach work here, like methotrexate for back pain?
This is a really crucial point. No. Conventional synthetic DMARDs like methotrexate, sulfasalazine, leflunomide, they are largely ineffective for the axial manifestations of PSA.
So giving methotrexate won't reliably stop the inflammatory back pain or prevent spine fusion.
Correct. If the patient's main problem is inflammatory back pain related to PSA, CSDRs are not the recommended treatment for that specific domain.
So how do you treat the spine in PSA?
For mild axial symptoms, the first step is often high-dose nonsteroidal anti-inflammatory drugs, NSAIDs. And importantly, they need to be taken regularly at anti-inflammatory doses, not just occasionally for pain relief.
And if NSAIDs aren't enough, or the disease is more severe?
Then you move directly to those biologic and targeted synthetic agents that have proven efficacy specifically in the axial skeleton. You don't typically cycle through CSDRs first for axial disease.
Which of the advanced agents work well for the axial domain?
The mainstays for moderate to severe axial PSA are the TNF inhibitors, the IL-17 inhibitors, and the JK inhibitors. All three classes have demonstrated significant efficacy in reducing spine inflammation and symptoms.
What about the IL-12/23 inhibitors? You mentioned them for peripheral disease and skin. Do they work for the spine too?
This is a key exception based on the clinical trial evidence. Generally, the IL-12/23 inhibitors, like ustekinumab, are not recommended as first-line biologics specifically for axial involvement.
Why not? They work elsewhere in PSA.
While they are often excellent for skin and peripheral joints, the data supporting their efficacy in pure axial spondyloarthritis, like AS, which is similar pathologically, has been conflicting and generally much less robust than the data we have for TNF inhibitors or IL-17 inhibitors in the axial domain. So if axial disease is the primary driver, you'd typically choose a TNF, IL-17, or JK inhibitor first.
Okay, that's an important distinction. Now let's tackle managing those really specific PSA domains, enthesitis and dactylitis.
Right. These often respond pretty well to the systemic treatments we use for the peripheral arthritis, like the CSDRs or the biologics JK inhibitors. But local measures can also be important.
What about for enthesitis, that heel pain, for instance?
First line is often NSAIDs again. If a specific enthesis is really bothering the patient, a local glucocorticoid injection, a steroid shot right into that tender spot like the plantar fascia insertion, can provide significant relief.
But you mentioned a huge warning about injections earlier.
Yes, absolutely critical warning. Glucocorticoid injection must be strictly avoided directly into or around the Achilles tendon.
Why?
Because it dramatically increases the risk of the tendon rupturing, which is a catastrophic complication, often requiring surgery. So for severe Achilles enthesitis, systemic therapy, like biologics, is much preferred over local injection near that tendon.
Okay, noted. Avoid the Achilles. What about dactylitis, the sausage digit? How is that managed?
Mild dactylitis might improve with just NSAIDs or the CSDMARD the patient's already on. However, moderate to severe dactylitis is generally considered a marker of more aggressive disease.
So it usually requires stronger treatment.
Yes, its presence is often a strong indication to escalate therapy to a biologic or a JAK inhibitor, as these agents tend to be highly effective for resolving dactylitis.
Can you inject a sausage digit?
Sometimes a local glucocorticoid injection can be considered, but it's tricky. It must be injected carefully into the inflamed tendon sheath surrounding the flexor tendons, not directly into the tendon substance itself. This often requires ultrasound guidance to ensure accurate placement and, again, to avoid causing tendon damage or rupture. Systemic therapy is usually the main approach for significant dactylitis.
And we need to re-emphasize the warning about systemic steroids, right? Oral prednisone, for example, generally avoided.
Yes, a really important point for PSA specifically. While oral glucocorticoids are often used in other inflammatory conditions like IA, they are generally avoided or used with extreme caution in PSA.
Why the hesitation? They reduce inflammation quickly.
They do, but the problem is the potential rebound effect on the skin when you try to taper the dose. Rapidly tapering systemic steroids carries a high risk of triggering a severe, generalized flare of psoriasis. This could manifest as erythroderma, where almost the entire skin surface becomes red and inflamed, or pustular psoriasis, both of which can be serious, even life-threatening.
So the risk of a major skin flare often outweighs the short-term joint benefit.
In many cases, yes. While a very short course with an extremely slow, careful taper might occasionally be necessary in a truly severe multi-domain flare, clinicians are generally very reluctant to use systemic steroids routinely in PSA, especially now that we have so many other effective systemic targeted therapies available.
Okay. Lastly, let's think about the long term. Beyond the joints, what about prognosis and those systemic comorbidities we touched on earlier?
This is a critical aspect of managing PSA. These patients face a significantly increased risk of several major health problems. We often talk about cardiovascular disease, heart attacks, strokes. They also have higher rates of metabolic syndrome, type 2 diabetes, and non-alcoholic fatty liver disease.
Sometimes summarized by that acronym DHEADM.
Right, diabetes, hypertension, elevated lipids, atherosclerosis, metabolic syndrome. Basically a cluster of cardiometabolic risks fueled by the chronic systemic inflammation of PSA. This increased risk definitely impacts long-term prognosis and can reduce life expectancy if the inflammation isn't well controlled.
Is there any evidence that treating the PSA effectively helps reduce these other risks?
Yes, there is some encouraging news there. Studies, particularly with the TNF inhibitors, have shown that effectively suppressing the underlying inflammation can be associated with improvements in markers of subclinical atherosclerosis, things like carotid artery thickness. It suggests that treating the PSA itself may help mitigate some of that excess cardiovascular risk.
That's good to know. What factors predict which patients are likely to have a more severe, destructive course of joint disease? Who needs the most aggressive treatment early on?
The disease course is highly variable, as we've said, but several factors at diagnosis tend to predict a poorer prognosis and argue for hitting the disease hard and early. These include having a polyarticular presentation, many joints involved from the start, having high counts of swollen and tender joints, having elevated acute phase reactants, ESR, CRP, even though they're not always high, the presence of dactylitis, already having visible joint damage on baseline x-rays, and potentially certain HLA types.
So if you see those features, you need to be particularly aggressive with treatment.
Absolutely. The goal is to prevent that irreversible joint damage before it occurs. And we really can't forget the impact on mental health either. Depression and anxiety are highly prevalent in people living with chronic inflammatory diseases like PSA. It's crucial to screen for and address these. Also, it's worth noting that a couple of specific PSA medications, Primalisd and brodalumab, carry warnings about a potential association with suicidality in rare instances, so they need to be used consciously or avoided in patients with a history of severe depression or suicidal ideation.
So managing PSA truly requires a holistic approach, considering joints, skin, systemic risks, and mental well-being.
Exactly. It's about treating the whole person, not just the joints.
Yeah.
#TakeTagOutro.
Well, this deep dive into psoriatic arthritis has certainly underscored its true complexity. Just to recap the core takeaways, PSA is really defined by its extensive heterogeneity. It can look so different from one person to the next.
Yeah, from that asymmetric oligoarthritis all the way to the potentially devastating arthritis mutilans. And its unique signatures are those specific soft tissue inflammations. Dactylitis, the sausage digit, and enthesitis, that inflammation right where tendons attach to bone.
We also established that PSA stands out because of that paradoxical effect on bone simultaneously causing erosion and new bone formation, a kind of ordered chaos driven by genetics and environmental triggers.
Primarily acting through those key immune pathways, the IL-23, IL-17 axis, and the TNF pathway.
And perhaps most critically for managing the disease, treatment demands that highly individualized, domain-based approach. You've got to select therapies based on what's flaring the spine, the skin, the peripheral joints, the entheses.
And always with that proactive treat-to-target strategy in mind, aiming for remission or low disease activity, and recognizing just how vital early intervention is, ideally within that first 6-month window after symptoms start.
The ongoing research into pathogenesis, particularly the role of the microbiome, the genetics, and especially mechanical stress, seems to be constantly refining how we think about this.
Absolutely. That concept of mechanoinflammation, the idea that environmental factors like physical stress can trigger inflammation locally at the entheses, is really central to where the research is heading.
Which brings us to a final thought for you, our listeners, to maybe mull over.
Mm-hmm.
Given that we have such strong evidence now that physical trauma can trigger PSA, that deep cognirization, and knowing that biomechanical stress seems fundamental to driving enthesitis, how much of PSA progression, especially in people we know are genetically predisposed, could potentially be mitigated or maybe even delayed?
Could things like really intensive early physical therapy or specific preventative biomechanical strategies perhaps play a bigger role? Maybe even supplementing, or in some cases preceding the first pharmaceutical intervention.
It certainly suggests the conversation around managing this complex and often devastating disease is clearly far from over.
Indeed it is. Lots more to learn.
Thank you so much for joining us for this deep dive. We'll catch you next time.